So I am Sheila Martins, President of the World Stroke Organization, and on behalf of the Global Coalition for Circulatory Health, I'd like to welcome to everyone for this very important and interesting discussion about circulatory health for all, investing to reach universal health coverage and prevent pandemics. So the circulatory diseases are the #1 killer in the world, with 20 million people dying each year, caused by mainly myocardial infarctions and strokes. This requires urgent action. Considering the burden of disease criteria defined by morbidity, mortality, and disability, circulatory disease are the #1 cause of death and disability, with more than 374 million lives lost each year, with a huge social and economic impact. When we talk about circulatory disease, we are talking about similar disease in different territories: the heart, the brain, the kidney, the peripheral vessels, with the same risk factors. And for this, we unified our efforts, working together in the Global Coalition for Circulatory Health to strengthen our voice and the voice of people affected by circulatory disease, to influence policymakers contributing to decrease the global burden of circulatory disease. The incidence of circulatory disease is increasing in the world, suggesting that the current strategies are not enough to prevent them. At this time, most countries are unlikely to achieve the target of Sustainable Development Goals 3.4 to reduce by 1/3 premature mortality from non-communicable disease by 2030. Especially during pandemic, we saw more severe strokes, severe myocardial infarctions, and more younger people affected, with higher prevalence of risk factors such as hypertension, diabetes, obesity, unhealthy food, alcohol abuse, and sedentarism in the population. The population with non-communicable disease was the most affected during the pandemic, with higher mortality. The hypertension is the #1 risk factor for death globally and affects more than 1 billion people. Dyslipidemia is the main risk factor for myocardial infarction. Diabetes can increase 2 to 4 times the chance of death by cardiovascular disease, and kidney disease, the main cause of death, or cardiovascular disease too. Yesterday, Bent Mikkelsen showed it in the launching of World Health Organization Global Hypertension Report that 46% of people with hypertension are undiagnosed, 58% untreated, and only 21% of hypertension people have blood pressure under control. This is unbelievable, because we are talking in the #1 risk factor for death and the #1 risk factor for strokes. And if we change this, implementing programs that are already available as World Health Organization HEART's program to early detection, treatment, and control of hypertension and other risk factors. It's estimated by World Health Organization, if we control blood pressure in 50% of the hypertensive population, from now until 2050, we will avoid 120 million strokes, 79 million of myocardial infarctions, 17 million of cardiac heart failure, and 76 million of deaths. This is huge. Hypertension, diabetes, dyslipidemia, tobacco use, obesity, sedentarism, unhealthy food, alcohol abuse are the main risk factors for circulatory disease, but also poverty. Poverty increases the risk of circulatory disease, and circulatory disease increases the poverty. So how to make the difference in this burden? How to change this reality? We know that 9% of the circulatory disease can be prevented. We know what needs to be done, but how to implement? how to expect that more poor people that is more affected by circulatory disease should pay for the treatment out of pocket to treat asymptomatic risk factors, silent killers, a stroke, or a myocardial infarction occur. How will the population decide between buying food to feed the family or medication to treat an asymptomatic risk factor? They cannot understand this. They cannot pay for this. So this circle, this cycle, poverty, disease, and poverty will never end without universal health coverage. How governments can choose what to invest and how to invest. Our recent position paper from Global Coalition for Circulatory Health called The Road of Universal Health Coverage, why integration of circulatory health interventions in primary care is essential, can help the governments to decide what, how, and why to invest. The paper, with a clear and short list of recommendations, evidence-based for circulatory disease, can contribute for 2 of the 3 high-level United Nations meetings occurring here in New York related to health, pandemic prevention, preparedness and response, and achieving universal health coverage. The focus of the paper is screening and prevention of hypertension, diabetes, cardiovascular disease, strokes, and renal disease, pharmacological treatment for primary and secondary prevention for free, and implementation of lifestyle modification, the who best buys low-cost strategies. The 3 key messages in the position paper for policymakers are: expand universal health coverage for circulatory disease by 2030 to reduce out-of-pocket expenditures, make primary health care a priority in national health budget, and prioritize effective and cost-effective interventions for circulatory health in the design of United Health Coverage benefit packages. But always important to remember that prevention is fundamental and should be implemented as priority, but the circulatory diseases are occurring now, and the acute care is important to decrease disability and mortality. So we are calling also for the importance of the universal health coverage across the continuum of care, from promotion, prevention, acute care, rehabilitation, and palliative care, with the implementation of effective and cost-effective interventions. I'm sure that together, as a coalition, we can make possible the implementation of best recommendations for circulatory health and make health accessible for all, ensuring equity, quality of care, resulting in quality of life and less deaths. Thank you.
Thank you. Thank you, Dr. Martins. Thank you for that wonderful introduction of who the Global Circulatory Coalition is, and really our policy paper. And so I would invite you to consider downloading it on our website to learn a little bit more about our coalition. What I'd like to do now is call our panelists to the front of the room so that we can begin a discussion on really what is happening at the grassroots level in countries. And so with the distinguished Dr. Enrique Tagan, the Undersecretary from the Philippines, please in front of the table. And we'll have you seated right over here. Also, can I have Dr. Andira Levin from the International Society of Nephrology, who is the past president, also take a seat. Dr. Tom Gaziano, who is chairing the Science Committee at the World Heart Federation, to also join me up here. And Mrs. Reva Greenberg as well, please. And so I'm going to just start asking the questions from the podium. And I'm going to direct the first one to the Honorable Dr. Enrique Tayag, who is the Undersecretary of the Philippines. Dr. Tayag, I know that the Philippines has obviously been one of the countries that has been playing a huge part in universal health coverage. Can you please tell us how you're tackling the issues of non-communicable diseases in the context of the discussions that are happening this week around universal health coverage? Please, over to you.
Thank you and good morning, everyone. And we are happy to join you here today to share with you the perspectives from the Philippines regarding this specific problem that we continue to face. In the Philippines, the leading causes of death are due to cardiovascular diseases that include ischemic heart disease, strokes, diabetes. And because of these, the Department of Health always makes decision on data that is available to us. For example, there are over 310,000 deaths due to ischemic heart disease. And we are now scared because it is becoming relentless even during the pandemic. Even the COVID deaths cannot actually outrun ischemic heart diseases. We're now looking at the data for excess deaths due to the pandemic because we believe when there were so many restrictions, many of the patients requiring access to these services so that they can reverse any of the complications that have set in will actually be minimized or avoided, but it didn't happen. And so therefore, when we look at this particular concern in the Department of Health, our strategy was not only to look at the biomedical aspect of the problem, but look at the social determinants as well. So we have changed our mindset. Very early, I remember 20 years ago, we already saw the transition wherein we were moving out of the infectious disease or communicable disease categories into the non-communicable disease categories. And I'd like to refresh your memory in the Millennium Development Goals, the world missed this, the non-communicable diseases, because at that time, the data were not available for many countries that really the non-communicable diseases were actually giving the many problems, health problems across many countries at that time. And so we are playing catch up and we hope we don't fail. We have set our targets and it's based on data that's available.
Thank you, Dr. Teo, and thank you for your leadership again. I'm gonna go to now Dr. Levin to talk a little bit about this connection between circulatory diseases and again building out of the COVID pandemic. How is it influencing, now our post-pandemic recovery from where you sit, and really when we think about strengthening the health system?
So I think the pandemic certainly unearthed or exposed all the weaknesses in the various healthcare systems, both from primary care and specialty care, and all of the activities related to prevention and early diagnosis that existed even in high-income countries were not accessible to patients. I think it also brought to the fore the vulnerability of people with circulatory diseases, be that heart disease, diabetes, kidney disease, or respiratory diseases, and how this connectivity between non-communicable and communicable diseases is actually quite important because they are the most vulnerable, the least access to healthcare at important times, or less able to get vaccinated, or had much more dire consequences as a function of getting an infection. I think interestingly also in many of the medical people have been appreciate this. A specific virus actually has an affinity for heart, brain, lungs, blood vessels, and kidneys because of the way that it binds. And actually what we're seeing with a lot of data that we have from around the world is that even well people who got infected now have evidence of early kidney disease, early heart disease, or have unmasked it. And so we may be seeing another wave of non-communicable diseases now in younger people, which is actually quite frightening. In fact, the House of Lords in the UK first asked what will be the impact of this, of people that recover from this virus on heart disease, lung disease, and kidney disease, because they understood the biology. And I think that's something quite, I don't think we've quite put together yet in terms of the next 10 years. And so I think from a totality of the individual perspective, it's important that we look at the systems that our patients have access to, primary care prevention, but also to engage patients to understand what the risks are, because there are many places in the world where there will continue to be a dearth of primary care access, let alone specialty care. And in as much as that will continue for at least another decade, if not more, we need to have different ways to engage people and have them access some of the things that we now know are effective in terms of impacting all of the fields or diseases.
Thank you, Dr. Levin. Going to Tom now, Dr. Gaziano. I know, and the Undersecretary really spoke to the connection with poverty alleviation and the impact of the risk of both having non-communicable diseases and infectious diseases. Are you, in your capacity, and certainly as in the role of science chair for the World Heart Federation, looking at working with these most vulnerable populations around the world and how they're being affected? And give us kind of what we need to do in the case of really addressing poverty, NCDs, the cross between the two and the connection. Over to you.
Sure. I have two hats that I wear. You mentioned I'm chair of the science, and then also a clinician and still practice and spend time in South Africa and in India and Argentina. And so this question is right from how you're talking about. For a couple of things we can make. Us involvement in evaluation. From policy perspective, you see that people, as you suggest, not only are they're likely to develop or be exposed to some of these risk factors, and these infectious diseases, unfinished business, heart disease, chronic conditions, etc. But when they develop cardiovascular disease or kidney disease, get access to these therapies. They can get into catastrophic for that period of time. And so there's a vicious cycle. They get there and continue to do worse. And so, even from a lower level, this seems to be a challenge. On a personal level, too, I remember a story. I was in South Africa. A patient came to me, walked several miles to get to the clinic. In about 5 in the morning, I was in a township outside of Cape Town. And that one morning, walked several miles to get in the queue to get to this clinic. The average wait time in South Africa about 3 hours to see me. Finally got to into the queue to make it to see me, and I found yes, I think he just started a blood pressure medicine because it was high cardiovascular risk. I walked out later in the day, 4 in the afternoon, when the clinic shuts down. He was sitting there on the curb, checking what happened. He says, "Well, I saw you went to the pharmacy queue, and it closed down before I could do it." In fact, one of the times, and they were at the end of the month, and they were out of stock. I never saw them around, so I didn't know what he had stroke or he had renal failure. But they figured out another way to get his medicines. But things like that, it's not here to help him. He missed the day of work to do that. He would have to miss another day of work to come back. But some of the things we take for granted in many countries where we mail to you, digital payments. So I think that those are the structural things. So that I think it's pointing out the Circulatory document. It was wonderful that it highlights some basic things we need to have some kind of approach to back on the policy had now. That you need to do. One is you need to, it's on 3 foundations, behavioral. We need to make sure that we take care of, and that means policy around the fact that we're smoking. It's not just people starting to smoke that we access to food and easier abilities to do physical activity and everything. But we often stop there, and that bothers me too. I'm like, why? And this is related to false armor. I used to get in arguments sometimes. Like, I do help and say, we can't give everything to everybody. You keep trying to get to more basic things. And so there is an opportunity for us to say there are components of that. You can't say that we're just get lifestyle, we just need to get thinking about that. But in access management drugs are $5 a year for blood pressure medicine and prevent stroke or kidney disease or cardiovascular disease. We need to make that available. So, and then the final thing are the structural sort of changes that need to happen. We need a system that can provide due to medicines or treatments that are available to them. Not all of them, and you have to understand that you have to rational about that, but there may be available. But it may not be delivered in the same way in 90%. I prescribe a cardiologist professional medicines. I'm working with nurses in South Africa. They're doing just as well or better than following a simple outbreak. These high, treatment rates are higher in studies in Africa. It's higher and higher than some clinicians. So we need to rethink about that. But that includes regulatory changes in terms of who has prescribing authority. I was gassing coming in South Africa, for example, the nurses eventually got authority to prescribe antibiotics complex regimens, but they couldn't prescribe a thiazide. And so that's great. So those are the hurdles we're dealing with. So if rubber meets the road, there are regulatory hurdles to do that, and then the relationship between health workers and nurses in certain parts of the country are not robust and helpful. We don't hear from try to break down these barriers. So there are some structural things that we need to do in each country, locally sensitive to what those needs are to address this issue of the most impoverished.
Thank you, Tom. That it really provides a great picture of the complexity associated to rendering the care, and then what do we need for an enabling environment, which means that we need policies, we need regulation, we need a host of other low-cost interventions that we know are proven. I want to move now because there's a story. I think each of you have talked about the people and who you're serving as clinicians. And I want to go ahead and show the reel first and then introduce Reba to the group. So I'm going to be quiet and I would take your attention to the screen here.
Reba, tell me your story.
I've had type 1 diabetes for 51 years, and when you need insulin to live, you always feel vulnerable to cost. And I've had a lot of years where you were never sure what the price of insulin was going to be. I'm thrilled that you guys got the $35 cap for Medicare. It's helped me afford my continuous glucose monitor, which is so important to me when I'm walking. And this is one where government and patients win over pharma.
Thank you. Thank you. So that gives you a little context of who Reba is. And we know that no panel and we can't talk about this issue without really lending itself to the perspective of the patient and the individual. And so Reba, over to you. I would really want you to shed some light on this conversation, the conversation that's happening this week around universal health coverage, how you really are living it. So over to you.
Sure, thank you. So unlike my esteemed colleagues, I'm going to reach for my notes. That clip was done only a few weeks ago because we did a rather amazing thing here in America. We passed a cap for the cost of insulin for people on Medicare. And it's really patients who made that happen after years of struggle to get the government to get pharma at a lower cost. So while this idea of universal health care, I think in a lot of places is a dream, on our way to realizing it, there are good things we can do and good things we are doing. And I think we always have to keep our eye on that, right? So like you, I'm advocating for health, for me specifically diabetes and having to do with circulatory disease. Every comorbidity of diabetes is a circulatory condition. So, the two are walking hand in hand. I wanted to share a story. When I was in Bangalore, I was doing some pro bono work at a diabetes clinic for the poor, and I saw a 22-year-old girl there who could not put her hands together. And this was because for all the many years she had diabetes, her doctor would never give her a meter. Instead, he sent her to the lab to get her blood sugar like every 3 months. Why? Because he was getting a kickback from the lab. And it was only when she found Dr. Shukanta, who had founded a diabetes clinic there for the poor, that she was able to get a month's worth of insulin and test strips every month. So, you know, it amazed me, right? That stuff like that is going on all the time, everywhere, that kind. And just this past weekend, I was called on for a contact I had in Panama to see if I could get insulin to a Panamanian mom who was here vacationing with her family because she miscalculated how much insulin she needed for her 12-year-old son, Diego. Only got type 1 2 years ago, and she ran out of insulin. And she was terrified. And here, it would have cost her, we don't have universal health care, it would have cost her thousands of dollars in the ER and all that time spent, the day's worth. And so, you know, I was fortunate enough that I could prepare insulin. So I went and met her, and, you know, we had this like drug handover, and I gave her the insulin. And thank God, day saved. But in part, I could spare insulin because my husband, on a business trip to Canada, brought back 10 insulin pens for me, where they do have universal health care, and it's 1/10 the price. So those are the kinds of circumstances, right? And inequity we're living with every day in this planet that we all share. So what to do, you know? So I think we have to think with our heart to save these beating organs and our bodies. And, you know, I thought about what I know is being done and has been done that's improving things. So societally, we have to come together in ways that we can figure out to come together, right? I know we so often say there's so much talk at these events, but there are some good things going on. So in Singapore, there's a hospital where healthy food costs less than unhealthy food, right? So healthy food costs less. So brown rice costs less than white rice. So it's an incentive when people come to eat healthy food. This is for the visitors, right? But they also built this hospital so that every room has a view of greenery, because we know that makes people feel better. That saves hearts. In Helsinki, they put in a slew of bike paths recently. So I think the bike paths rival roads. And so people have safe place to get more exercise. And I'm working with somebody at Harvard University right now, who's working with a partnership with NCDs Poverty Network, where they're building clinics and getting healthcare access to the poorest people in Africa. And yes, I will find out about Rwanda. So good things are happening, and we have to see what we can do collectively to make more of that happen. At the same time, I want to say there's something we can do individually for our own heart health. So I'm going to ask everybody to get up.
Stand up.
We do an awful lot of sitting. So this is a somatic exercise based on somatic science. Make sure you have enough room around you so you can comfortably, easily stretch your arms. Don't lock them, but, you know, a little gentle relaxation, okay? And very simple. I know everybody can do this, but if for any reason you can't, don't do it. So bring your arms forward so that your head comes forward. You're bending from the shoulders, the neck, and your thumbs are going backward. Yeah. Okay. Then relax while you're doing this. You can laugh if you want to. And then go in the other direction. Come straight, bring your arms, bring your neck and your head and your shoulders back. Your pinkies are going up. Relax. Just take a moment with that. We're going to do that one more time. So come forward gently, easily,
Bring your arms and shoulders forward, your thumbs are back. Relax, take a breath. Okay, now back. Pinkies up, thumbs back. Okay. Now come to center and just feel if you feel anything in your body. Okay. And you can put your arms down. And you can sit down. So what we've just done is increase the blood flow, right? Simple enough. Done good stuff for the heart and the circulation. And think about the simplicity of why couldn't doctors share this with their patients, right? On an ordinary visit. It's a means towards prevention, keeping ourselves healthy, something we can all do easily. So even thinking about the simplest things can make the biggest difference. I just want to close by saying I've had type 1 diabetes for 51 years. And with that, I've had 2 frozen shoulders, 1 trigger thumb, a little neuropathy from time to time in my calves, and some hearing loss. All circulatory related, as all diabetes conditions are. But I've also had the joy to do this work and educate people as a peer mentor who live with it, and also our health professionals to work with we who have it in a way that creates more compassion and trust and the ability to flourish with it. And the day I brought the insulin to the Panamanian family, I was meeting them at a diner and they were already seated for brunch. And I couldn't help but see the heavily fried chicken and the thick waffles that everybody was eating. And of course, everybody was overweight. And I thought, in rural Panama, in every place in the world, like rural Panama, we have to make sure we educate people what to do. Somehow it's easy to think we're so knowledgeable that it's easy to think people know more than they know. In fact, I just learned something today. So this is, as someone living with this condition, how I see it. So my only urgency is whatever we think we can do individually and collectively, let's do it and keep doing it. And eventually things will, if universal healthcare doesn't happen, some good things will happen. So thanks.
Thank you, Reba. Thank you, Reba, for really getting us to move and stand up, and for telling your really powerful story about how human-centered design really sets the stage around the individual to make care a quality care, one that's really addressing your very specific needs, and for being so giving, showing your generosity and taking action. And I do want to go to the Undersecretary again, the Philippines, to really speak to this issue that I think, Reba shared about. You're in the halls, the very important halls at the United Nations, having these discussions around universal health coverage. And I would just be interested, as you see it, what are you hearing? Like, tell us, because a lot of us are having a hard time trying to break in. But tell us, what is it that you see as the important role civil society organizations need to continue to have? Revisit advocate, and we are really trying to put the stories in those halls, but sometimes we don't have access. Tell us what we need to continue doing, and what things we need to continue doing for governments to hear and to change with this opportunity ahead of us.
I was impressed with that. A round of applause.
Yes, that's right.
fact, I can dance in front now. For many years, I've been advocating this kind of stories. In fact, just several hours ago, we were met with a sad story that one of our colleagues suffered a stroke. There's no exemption. It disregards any statistic. Would you believe that almost 20 years ago, I was 60 pounds heavier? I lost all of them when I was one of those who experimented on the Atkins diet. But I moved away from that. And there were several studies right now that we try to verify, validate, so that we can really help most of the people. Now, why do we need civil society? Civil society speaks the language of the people. We speak science, and it's kind of difficult for government to translate these policies into simpler things. And so civil society's role is to make sure that we work together, but at the same time, send a message which is more simple, clearer, so that then we can change their behaviors. Right now in the Philippines, we changed the way we look at disease. We started with the basic fundamentals, and we're working with society, looking at the basic health literacy of Filipinos. We've done surveys, we've told, and it surprises us that even those in the middle income and rich populations, health literacy is not something that we should be proud of. And we're also looking at the influence of social media. There are influencers there that give advocacies. We know in their hearts they're doing the right thing, but it doesn't give the people that sense of confidence or trust, because these messages may in fact be detrimental or harmful, and we're not able to regulate. And one of those things that we want the civil society is to make sure that they are part of the decision making. In the Philippines, health is devolved, and it is the local chief executives who chair local health boards. And one of the members of the local health board is a representative from civil society. So unless there's magic among those members in the local health board, then the needs of the community, including non-communicable diseases, or what we're discussing here, will not be prioritized. So in the Philippines, we work with civil society to pass several laws: tobacco control, sin tax, sugar sweetened beverages, trans fat. But all of these are policies. We want to enforce them. And so we want to change the equation wherein civil society actually brings forward more mindsets that will have to be changed regarding the government can provide the environment or the setting so that this can happen. The civil society can provide very good examples, just like we've done. A simple method to increasing blood flow is something you can start. And there are many things we can do simpler. For example, the way we read. I remember I had a watch and it tells me, read. Oh, I was not reading. And many years ago, because I'm an epidemiologist, and we're looking at our data for the leading causes of death. And because I know data is very, very critical for our decisions, I'd like to know what was our number 8 leading cause of death. Stop breathing. And so we have to educate decisions to make sure that these death certificates are filled out correctly. We have to tell them, if you do not learn how to fill out that certificates, how can we even interpret or make an analysis of our data? How can we have policies that can actually have impact when the data doesn't show because of these things that we have to do?
Thank you.
Errors, right?
Yeah, thank you. Thank you for sharing your story as well about the fight to become healthier, to taking action yourself.
Oh, Jana, if everyone has to know.
No, well.
I dance a lot.
And you
can dance.
I mean, all the dancing that.
Stay, we're gonna play some music and afterwards we're gonna.
Now I understand.
Thank you for reminding us too that we are, civil society has an important role. We are giving the language of the people. I love that, and we're gonna take that with us, but reminding us too that it's, driving down solutions at the very local level. Even though we're global, to always remember local is where things start, right? And things begin, and things happen for real people. I want to go to Dr. Levin here as our time is ticking here, and I do want to throw it out to the audience as well. Is to tell us a little, just share with us a little bit about breaking the silos. I think one of the charges of the coalition was exactly that, right? For us to start working together. Shed some light on, do you think we're making progress in that area? What do you recommend? So over to you, Dr. Levin.
So it's a big question, but can I just quickly address the health literacy thing? Because on top of health literacy is the fact that all of us, when we go to see doctors or are dealing with health, might get anxious or are depressed. And people fail to understand, like, it's so hard to talk to someone if all they are is anxious that you're going to tell them they're going on dialysis or they're going to have their heart operation. And so stopping and seeing what it is that they want to talk about is also really important. Otherwise, they can't then learn even the basic concept. I think we sometimes forget. And as clinicians, we try and do that even in limited time. So in terms of the silos, I think, there's been a few experiments around the world where we try and do polyclinics. We did a heart, kidney, diabetes clinic. And those are places where you break down the silos and the person is there and you don't have to go to a few different appointments to talk about things. And then the doctor goes, you can have a primary care physician, gets a note, a combined note from all three, so they don't have to read 2 different things. Now that's a bit utopian. We did that as a study, but that's the way to break things down. However, to Dr. Tom's point, our systems aren't set up like that. And the remuneration or the way that people hear things don't necessarily support that kind of integration. I think the coalition is a great example of circulatory health and reminding people that we have one body, which has blood vessels, which feeds all the organs, is really important. And perhaps that message about how the interplay works is better. There are drugs that prevent kidney disease, heart disease, and help with diabetes, and they're one drug. So maybe that's another way to go, to remind people that the risk factors are in common, some of the treatments are common, and that together we can actually reduce, heart failure, kidney disease, and improve diabetic control. So maybe those are messages that we could be a little bit more forceful about. But I think, and I go back to engaging the patients to understand that they don't have 3 diseases. They are one person and they have conditions that affect many organs, and working out systems so that we don't have to send people to 4 different doctors or 5 different doctors. And I got a call yesterday about someone who had a kidney problem, a neurological problem, and an inflammation problem, which turned out to be an autoimmune disease. But because there wasn't the availability, despite my wonderful universal healthcare system in Canada, because there wasn't a rheumatologist, nobody knew what to do. And I said, well, for goodness sakes, certainly an internal medicine doctor can prescribe a medicine to reduce the inflammation so that they get better and save those organs, which already have evidence of failing. And I think, you know, taking personal responsibility, but the system needs to take responsibility to letting people access at points of care, like the right, we use this a lot in medicine, like the right person in the right place with the right medicines at the right time. But I think we need to review how we created our healthcare systems that are created and those that aren't very formal, how to make sure that we don't deny access in a timely manner for things that need attention.
Thank you, Dr. Levin. So since it's a small and cozy group, what we're gonna do is we're gonna spend the next 10 minutes so that we can wrap up and I can turn it back over to Dr. Martin. Is there any questions that you would like to pose to any of our panelists, or just reactions of your own experiences and what you know is working in your particular case? Yes, Dr. Martin.
Well, thank you first for just wonderful comments. They were extremely interesting and very useful. I want to follow up on your comment on the pandemic, because if we are thinking of the burden of disease, the pandemic cannot match the burden of circulatory diseases. And when it was a pandemic for the COVID, the money was there, everybody was reacting, it was possible. When it's a circulatory diseases, no, it's not that way. So I agree we need to change the mindset in the population and also in the politicians to do so. And what we have in common is this enormous preventive potential, which is our glue that we have in this collaboration. And also we have the possibilities of therapies, which is remarkable. Just want to mention to you that in Sweden over the last 10 years, there is a reduction in intracerebral hemorrhage by 20% and a reduction in ischemic stroke by 17%. These are data that was published today, released today, but it shows a potential that is so enormous and that we need to really put forward. So thank you.
Okay, maybe a comment. I think I'm not sure why it's so hard to convince people that spending $5 a day or $10 a day on your workforce, because in most countries, these diseases are affecting young people and in a lower middle income, even younger. I'm not sure why it's okay to spend a lot of money at the end fixing things that you could have prevented. And I don't know where the economic arguments are. Like, I think they're quite obvious, and yet, as you said, during the pandemic, the money flowed. During an emergency with flooding or fires or earthquakes, the money flows. So where is it when you actually needed to take care of people as a whole society? And I think maybe that's part of the advocacy, but maybe you can comment.
Political will, over to you.
Yeah,
Maybe you can speak to that.
Fear of the like that, and why there's an unprecedented fear of circulatory disease or non-communicable diseases. There is, which suggests, and I think that in many countries have been able to achieve this overall 3% reduction per year in age-adjusted cardiovascular mortality and stroke. And that's been primarily done through blood pressure treatment. Plus, we have very high-end treatments as well within these kinds of several studies. And then it's on K-12 and countries in the UK that looked at a portion of different things. It's about 50% public health measure smoking cessation. Efforts at improving physical activity, weight loss, et cetera, and then pharmacological or clinical health system interventions that have been a large part of that 3%. We would have gotten everybody to the 3% for goal. So I think to be, again, to sort of point attention to that document, it does require not getting certain details. Is finding, first of all, focusing as you know, on the big things, the big burdens, both in health and in cost. And so those are the ones included in the circulatory, but included in the answers. So then understanding that the smart, and then what are the cost-effective solutions, again, going back to it. So you can spend $5 in blood pressure control that affects that works on all of those diseases of the blood vessels in particular, and access to essential medicines, including statins and treatment for diabetics. Without breaking the bank, as we start to get bigger than that, I think getting devices and other things we do want to involve in advanced care, but I think we could get in this respiratory in a fight of some of the advanced care methods, and we can treat a heart attack pretty well. Structural kindness again cheap pretty well. You do cath labs and other pieces of it. I'm a cardiologist, but the fact that this exists. But I think at some point this is where some of these challenges are going to run into it. Because there are cost-effective solutions that have been promulgated by the WHO best buys in this industry that exist across the spectrum, supporting primary care and prevention, but also access to secondary, management. Then the third thing is, I think it's addressed the financial risk, protection that people can't be broken by $1,000 a month of that kind of prescription, maybe too much of some of that most awful. So that will take, and then a social commitment, there's a community commitment, understanding the education part of the civil society. We did all the work without notes too, so we want people out without notes, just arguing for the basic that we need. Because that part's really key. I'm working in Argentina where they have a universal health coverage plan. Everybody in Argentina, about 10% cardiovascular disease has access to about 8 antihypertensive medicines, 3 different cholesterol lowering agents, metformin. And we've seen less than 10% of the population is taking that up. Some of it because they don't know that they're high risk. So we've been working with the health workers coming to the clinic unless the culture still there is you go to the primary health center if you're pregnant or some part of your body hurts. You dance too much then, or your shoulder popping, you realize that's bothering you, or you have a fever or something else. And so you present this time with the idea of schedule appointments for chronic conditions. It's not common. And this, the last thing is that we have in banking and commercial products in the 19th century, most of what we do in our home. This is where patients want to be for the most part. They don't want to be in the doctor's office. You drive into my office in Brigham, you drive 40 minutes of traffic, you take $25 or $30 park. I might be a half an hour late. That's not a fun experience. Then some of that care can be done with you have a digital blood pressure cuff at home, and you can transmit it to me or to a nurse or somebody else saying, you don't have any manager, we talked about that, like 11 talked about there's barriers and if somebody has big means that not, I think actually may be causing fear in many cases. I think we need to be able to sure, but a lot of times we figured out we've been able to manage patients in their home, blood pressure program, remote monitoring, and having the medicines to them, get them out to the pharmacy, give them, have it delivered to them. Low income countries have to think about these solutions, and care doesn't always have to be in the primary care centers. I think that they're not making problems, and then they're not managing day to day and month to and people coming back every 2 weeks or 4 weeks with medications. So I think they have to rethink about that delivery. Or else it will be difficult. And that's what we're trying to do. But they had universal health coverage for a certain number of packages for promoting. They're not being used. It still is a problem. I think about needing to become easier for them.
Yeah, I mean, I think the report talks about the essential services that we see for Circulatory Coalition, but there's just a whole apparatus of human-centered design that needs to go into the thinking of those who are in charge, our policymakers, our health systems, etc. Rose, you had a question?
Yeah, thank you. I think I would like to thank Rebas. When I've been hearing the talk in this one, we are more focusing on disease rather than focusing on a person. And when she told us to stand up, it showed that she's giving that message of focusing on a person, not a disease. So how would we change the narrative as leaders and advocates for even our governments not to put a lot of money into disease, but to focus on the human rights and a person? So
I think that's a great picture.
Yeah.
Thank you for really illustrating that. So human rights, are we talking about the individual? Are we talking about the conditions that affect them? How would you respond to that? Who wants to take that question? Go ahead.
It's a hard one because different societies have different value system in terms of societal wellness versus acquisition of wealth, the haves and the have-nots. And I think it's a really important question. I think there isn't a one solution for every country. I think putting people first. I live in a country just here that has a different, like we have a lot of income tax, but we take care of everyone. Everyone has healthcare. It doesn't mean that everybody gets healthcare, but everyone has access. And then we have a different problem of rural and remote. And I think that in every country, there will be different geographical, political, religious, cultural barriers to human rights to health. But we have learned from our patients that they would rather, when we talk about kidney health, not kidney disease. And so that's when we go to rural and remote communities, we're looking for how healthy you are, not how sick you are, and that's helpful. I think I also want to comment that in many countries, highlighted in exactly, instead of healthcare workers delivering these things, they have community workers. And so there's a bit of a hub and spoke thing where in smaller villages and even larger ones, there are people trained to take blood pressures and run point of care machines and talk about pregnancy and wellness and good nutrition to the community that are community members. They're not, and they're trained and educated, but they're not doctors or nurses or anything else. And maybe engaging society to help each other, sounds very lofty, might be one of the ways that you recreate that sense of community, no matter how small or big the borough or the neighborhood is. And there's a nice couple of experiments in the US where talking to people about their blood pressure and getting them measured in the barbershops, because you see a barber way more frequently than you actually see your primary care, was very effective in getting people to understand the blood pressure in a non-threatening situation and take their place. So there are things we just are not very good at scaling them. When we hear about things, that's nice, and then we don't actually think about how many other places you could do it.
That's a great example.
Good example.
That's a wonderful example, and it's interesting because they're using barbershops now to talk about mental health, because we use masseuses and our hairstylists to discuss our lives, right? Any others want to take that question before I call Dr. Martin back?
Well, I just wanted to add to the thought about community health workers, which I agree is so powerful. So when I was in Bangalore at this clinic, they were piloting a program for community health workers. And I got to see one, particularly in her small village, and she would go around to each of her neighbors' door, and she had a scale, and she had the simplest devices, and she would keep a record in a notebook of all her neighbors' vitals. And then every month, the clinic medical staff would ride 2 hours on the bumpy road out to her village, and all the villagers who needed assistance would come to her little campsite, and they would get the medicine and the treatment that they needed. It was far better, as you said, than expecting they're all going to get to the clinic. And again, it's this idea of a simple idea, right? And one based in our humanity. I think so much of what happens is where, as human beings, I think we tend to be more reactive than proactive.
Yes.
When money's concerned, we don't want to put much into prevention because we can't see what it's doing. But somebody gets a heart attack and you give them some expensive tests and do what you have to do on the operating table, you can see what it's doing. So it's funny, but there are some really human things going on that get in our way.
Thank you. Others from the floor before I call Dr. Martin? Leslie.
Yeah, I just had one last thought, maybe like a call to us as civil society kind of thing in the room, listening to some of these stories is maybe us trying to still do a better job of making that prevention case. I'm on the prevention side of things, so I work for the Global Alliance for Tobacco Control. So prevention is huge. But they put out those investment cases now. And so when you're talking to governments and you're trying to explain the return on investment or making the case for why you should be investing in these types of policies and programs is huge. And so I think that we have a lot more advocacy, I think, to do of why that's so important. And I understand your point about why invest in something if they're not gonna see kind of any immediate results. But when we were working with the college in Uganda, they said it's really hard for us to try and convince our government to put $500,000, say, or into a tobacco control program because they don't have it. So then the other option was, well, maybe you can increase taxes, and then that's another way. So there's not just a one-size model for them to kind of understand to put money into prevention. But I don't think we talk enough about that return on investment and kind of make that noise about the amount of preventable deaths. Not just NCDs in general, but for me, tobacco control. So I kind of like us to keep being loud about that. I think, you know, if there was 3 or 4 main arguments that we have in terms of investing, whether it's UHC or NCDs more particularly or something like that, but coming up with those 3 or 4 big like main messages that we just have to constantly drill into everybody's brain. And I think together we could do that, like come up with what those 3 big headlines are and just say it every single time you're speaking to someone, because I think that people don't understand from a government perspective, not saying you, but you know, within government is like the money's there. They talked about it today in a financing meeting on UHC is you know, the money was there, just like your examples for COVID, it was there for humanitarian things, it's there. And there's been a lot of countries who have come out, I think they give a few examples of how after, was it World War II, I think, how France came and put kind of their UHC plan into place. Maybe now is that time to make all of that noise about it because the money is there. We've just seen it multiple times. So yeah, I just wanted to leave that and maybe we're going to call for action.
Okay, so our call to action is to come up with those return on investment. The investment cases matter, and we need to shout it out. Sheila, may I ask you to come to the table? And again, we just thank all of our panelists for your interventions today, for the discussion we had with our guests, and over to you, Dr. Martin.
Thank you for wonderful discussions. Well, we saw here in these discussions that it's very important to work on country level because the same model don't fit to all. It's so important to know the reality, evaluating the gaps, and we as civil society can help to translate the evidence into practice, helping to find potential solutions for these countries. For implementation, it's important to show the evidence, and the majority of interventions we are proposing are not only effective and cost effective, the majority are cost saving. So it's so important to convince the governments about this. It's fundamental to monitor the progress. We cannot do anything without data to show, to see, to evaluate the situation and how it's progressing. Universal health coverage is the key for the success, and we hope these high-level meetings this week can bring us surprise and more implementation of universal health coverage across the globe. And partnership is fundamental with governments, societies, and public and private partnership to achieve our goals. So thank you very much for coming. Thank you.